Hi everyone, welcome. I'm Mingming Xu. I'm a gastroenterologist at Kaiser West Los Angeles, and I'm here to demonstrate today the placement of a through the scope or TTS esophageal stent. The stent we're going to be using today is the Boston Scientific Agile stent, which is a fully covered esophageal stent. It comes in 14 millimeters and 18 millimeters in diameter, and it goes through the scope, so it makes it for a very easy deployment. So what we have here, obviously, is we have a model stomach esophagus, and I always personally place a wire for wire-guided enteral stent placement. And we have a long wire here, and we simply advance the stent over the wire, and it's very easy, seamless kind of deployment here. So we'll just advance the stent over the wire. And normally, obviously, this will be done under fluoroscopy, presumably for an esophageal stricture. In this case, obviously, we can go across the strictured area because we're in a model. But normally, you would always have fluoroscopy as well to confirm the placement of the stent. So you simply just advance the stent through the scope with a little bit of tension from the tech to make sure that you don't lose your wire and the wire is in appropriate position as the stent is being advanced. You just need a bit of a back tension. And then you slowly advance the stent across the wire, like so. Should be coming out soon. Okay. And so here's the stent. The distal end of the stent is here. That is a metallic marking, so you can see that on fluoroscopy. And then that is the beginning of the stent. Obviously, you can see it very well endoscopically. So normally this would be a strictured area, and so you would not be able to see the stent advancing further into the stomach. But in this case, obviously, we have the advantage of endoscopic view. And then you just kind of advance the stent to the distal portion where you like it. And then you would ask the tech to start to deploy slowly. Do you want to talk about the couple points here on the marking of the stent? So this is essentially the point of no return, at which point you cannot recapture the stent. Up until this point, the stent is recapturable. So if you need to reposition it for whatever reason, oftentimes I'll just re-manipulate the scope. You don't necessarily have to recapture the stent. But worst case scenario, you need to actually recapture the stent. You're able to do that up until this point. So it's very important that you work with your tech and you're communicating to make sure that if you're close to this point of no return, that you're both aware that that's it, and that once you're past that point, the stent has to be deployed wherever it is. Okay? So we're going to go ahead and just start to deploy. And so it's a simple just pull towards the deployment, and you can watch it on endoscopic view and fluoroscopic view normally. And you want to normally, pause for a second. Normally when you're deploying a stent across a tight stricture, you'll notice that there is a pulling in effect. That's very natural. It's because the stricture is pulling the stent in. So you want to provide a little bit of back tension at the point where you're holding the stent so that the stent remains in the same position. It's not just getting sucked into the stricture. Okay, keep going. All right. Keep going, keep going, keep going. Okay, stop. So right before the point of no return, I will ask them to stop. I will try to reassess my endoscopic position, reassess the fluoroscopic position, make sure everything is in the right place, and we're in a good position here. And then go ahead and slowly continue to deploy. Okay. And you do want to push the stent out a little bit as well, because I'm not sure what the length of the stent that we're using. Okay. But that's the end of the stent here. You can see the line coming out. Okay, keep going. Okay, and that's the stent fully deployed. And at this point, you can recapture like he did. And I always actually keep the wire in. I usually do an exchange, with the stent to keep the wire in, just in case need to, for some reason, you need access if you need to bridge the stent or whatever reason. I keep the wire in until I can make sure that the stent is in good position. We just do an exchange. And then obviously you'll do your contrast injection through the stent to make sure that it's patent and it's going across the other side in the appropriate position. And I think that's pretty much it.
Do you ever worry about migration?
Yeah, so definitely with esophageal stents, any kind of fully covered stents, you obviously worry about migration. I think with, when you're placing esophageal stents for malignant strictures, it's less of an issue, but for benign strictures, it definitely is very high migration rate. I would say more so with the smaller diameter TTS stents than with the 23 millimeter, the conventional esophageal stent that's much bigger in diameter. A couple ways that you can avoid that. One is to place a really large stent in diameter and length. The longer the stent, the bigger the stent, it tends to migrate a little bit less. Not a guarantee. There's other like stent fixation techniques, like either suturing, endoscopic suturing of the proximal end of the stent can help. Ovesco has also been used as a fixation tool. So there's various fixation tools, but you always, when you're talking about esophageal stent for a benign stricture, you always have to talk to the patient about the migration risk and what that would entail and the potential for complication.